Today we will be demonstrating how to perform a cesarean section using a fan and seal skin incision. First, we are going to identify our landmarks on the abdominal wall and the skin. The fan and seal skin incision is usually made about 2 centimeters above the symphysis pubis, and we'll make a 12 to 14 centimeter transverse skin incision. We're going through the first layer of the abdominal wall, which is the skin. And underneath that, we should identify our subcutaneous fat. You can bluntly separate that until you get to your next layer, which is the fascial layer. Would you like to make your incision a little bit wider? Then we make an incision in the middle portion of your fascia, ensuring that you are just incising the fascial layer. Careful not to go deeper. You can see where the muscle is underneath. We are now going to extend our fascial incision laterally. You can do this bluntly or sharply. We are doing a sharp technique. We are dissecting the underlying muscle layers away from the fascia, extending that laterally. Extend that incision. You see our rectus muscles underneath, which is this white elastic. We'll identify the midline and separate that bluntly, extending your incision. And then we identify our peritoneal layer, tent it up to ensure you minimize injury to the underlying bowel. Make that entry, and here we see we have entered the peritoneal layer. We can then extend this bluntly. So you see the uterus underneath. We first then need to identify our bladder. We'll place the Balfour retractor there and find our bladder reflection. This is the view from above. We can see the bladder there in the just anterior to the lower segment of the uterus. We're retracting that away so that we can identify the vesicouterine peritoneal fold, tent that up, make a transverse incision with your Metzenbaum scissors. This allows us to carefully dissect that bladder away from the lower segment of the uterus. At this point, you can raise that bladder fold and push that down even further. We'll reposition that so we are protecting that bladder away. Now we are ready to make the transverse incision on the lower segment of the uterus, ensuring that we do this gently to avoid injury to the fetus. At this point, you'll probably have your suction helping with visualization. Once you make that transverse incision, you'll see the amniotic membrane. And you want to extend that uterine incision. You could do that bluntly using a cephalocauda direction or sharply using your scissors. For the purposes of this demonstration, we are doing it sharply, but you could insert your fingers and extend this cephalocauda direction to Now that we have adequate exposure, we're ready to deliver the baby's head, removing that Balfour retractor with some fundal pressure to assist with the delivery. We will do delayed cord clamping after the baby's delivered. At this point, you keep the baby dry and warm to allow for at least 60 seconds if appropriate. before clamping the cord. So once you get to your other angle, you want to ensure you go past the apex again, but be cautious that you are not going beyond it where the uterine vessels are. And here, after your single or double layered closure, you want to ensure you have good hemostasis along the uterine incision. You want to check both angles. Make sure again that you have no excessive bleeders. You check the integrity of your bladder. Okay, we are ready to close. We have identified the superior edge of our fascial incision, identified the inferior edge. We're going to check and make sure we have good hemostasis. Check the peritoneal edges, the muscle edges. Everything looks good. Now we are ready to close. We usually leave the visceral and parietal peritoneum to close spontaneously. So we'll just go ahead and start closing our fascia. Okay, we're ready to close the fascia. We are first tagging one corner, as you see here. This will just help with the exposure and helps ensure that you have good visibility and security to your closure all the way to the very end. You can use this technique for the uterine closure as well. We're going to the other end now. Again, ensuring you're just above the apex. So again, we're ensuring we have at least 4 square knots put down on these to reduce the risk of your closure running loose and to reduce the risk of dehiscence. We're doing a continuous running stitch on the fascial closure, making sure your bites are just about half a centimeter to a centimeter away from the edge of the fascia and from each bite. As you're closing your fascia, you're making sure that there is no other underlying structures coming in and getting caught in your bites, such as your bowel or the bladder. Okay, so we have just closed our fascial layer. We are ready to look at the subcutaneous tissue, the fat layer. If it's more than 2 centimeters, some people would put several interrupted sutures in the subcutaneous layer, and this has been shown to reduce the incidence of dehiscence of your incision. So we're just putting one interrupted layer in the subcutaneous fat here. You would do that, do a couple to reduce that dead space as well. If you have a very thick subcutaneous fat layer, some people would also do place a continuous loose running suture across. Okay, we're ready to start our skin closure. We will be doing a subcuticular skin closure. We're just anchoring our suture at the apex. We try to bury the knot and we pull this stitch out to the apex and we will be ready to start our subcuticular skin closure. So in this model, it's hard to really do a good subcuticular skin closure. So we are just coming through the skin, the epidermal layer, but when you're doing this, you want to stay in the subdermal portion of your skin. So we're nearing the end. We will bury the knot for subcuticular closure. So you pass that needle, just past your incision, and this will successfully bury your knot. And you can cut the suture right at the skin surface.